Welcome to the PTR Physiotherapy Rehab Podcast. My name is Warwick Schmidt, and in this podcast we interview subject matter experts, authors and elite athletes to help inform clinicians and patients and generate discussions around sports, rehab, health and how to get people back to their best. We hope you can take away some content and use it in your practice. Okay, welcome to the PTR Physiotherapy Rehab Podcast, where we focus on musculoskeletal physiotherapy and rehab topics. Today we have an esteemed guest, Tom Wainwright, who has published many papers on orthopaedics, and Ben SteeleTurner. I'm going to pass over for the introductions in a second before we dive into the main perioperative eating topic. So, Tom, if you could just give us a background on yourself and how you got into research.
Sure. First of all, thanks for the invitation to take part in the podcast. I'm really happy to help you guys. My name is Tom Wainwright. I'm a professor of orthopaedics at Bournemouth University and also a research physiotherapist at University Hospitals Dorset. I've been involved in research actively for over 20 years, specifically in research in orthopaedics. I probably have kind of three main areas. The first one is around hip and knee osteoarthritis and how we can prevent surgery. So what's the best non-surgical options for management? Second one is enhanced recovery after surgery. So if a patient does need their surgery, then how can we optimize that perioperative care for those patients? And then the third part is how can we optimize functional outcome post-discharge? Although hip and knee replacement are very routine operations, I still think that we could be doing a lot to improve outcomes for our patients after surgery.
Excellent. Ben, background on yourself?
Not quite so knowledgeable. I'm Ben, and I'm a physiotherapist. I did my master's in human nutrition, which I finished in 2018, and then I'm now currently a year into part-time PhD, where we're looking into upskilling physiotherapists to provide weight management for conservative knee OA.
Excellent. So there's a sort of bit of overlap between your two knowledge bases, which is hopefully will make up for mine, which is in the military and sort of healthier, younger population. So Tom, thank you for that. The paper that we're talking about, and hopefully we can drift, not drift, but smoothly move towards some advice from Ben on specifics. But Tom, can you talk to us about how this paper came about? How did you collaborate for this?
Yeah, sure. So my interest in kind of nutritional strategies around the perioperative sort of stage actually was some years back, where I published a systematic review with Professor Stuart Phillips from McMaster in Canada. So for any of you guys sort of interested in healthy aging and resistance training or exercise in the elderly, he's like a really pretty big deal, globally. So I had a great opportunity to publish with him, and we looked at the role of nutritional supplementation before and after hip knee replacement. And at that stage, there were a few papers, and there was a broad consensus that it could be helpful, but very little understanding of, is it helpful and for which patients and what should we be giving them? So I sort of maintained an interest in this, and then about 3 years ago, I got approached by a guy called Matteo, who's one of the co-authors on this paper, who was a PhD student from Milan at the Galazzi Institute, and he was interested in enhanced recovery and contacted me as I was the lead author on the ERAS Society International Consensus Statement for perioperative care for hip and knee. So he came over and did the sort of 3-month summer placement with us, and we had a great time actually exchanging ideas about his thoughts and what was going on in Italy and what we were doing in the UK. And then since then, we've continued the collaboration, and the paper we're talking about here is probably one of, I think, maybe 7 or 8 papers we've now collaborated on together. Essentially, I think we've come a long way. So enhanced recovery over the last sort of modern surgery has meant that we, are not at the stage where we're starving patients for 24 hours before their surgery anymore. We're encouraging them to eat up until 6 hours in most hospitals, and then the enhanced recovery guidelines say you can have clear fluids until 2 hours before, but now many hospitals in the UK, they've got this sort of thing called sit till send, where you can have clear fluids until you're sent for surgery. So we're not getting, the same kind of, I suppose, starvation effect in that initial, first few days. But more generally, I think what we can appreciate, and it wasn't this article, but it's in another article that we published recently, but if you look at the diet of people typically undergoing hip and knee replacement, they don't get enough protein, and your protein requirements in the initial days and then arguably weeks after surgery, when you start doing resistance exercise, require more protein if you're going to make those gains that you're hoping to. So I think it's something that there is much scope for practice and for us improving practice. I suppose then comes the concept of, should it be about nutritional supplementation as we originally looked, or should it be about education? And should this surgery be a touch point for educating patients about their diet and what their diet needs to look like in terms of the sort of macro and the micronutrients? So I think it's an interesting one because, we have 100,000 hip replacements, 100,000 knee replacements every year in England. There's a big population. But what it isn't, it's not life-saving surgery. So whereas, with heart surgery or, you see cardiac rehab patients, they can make sort of 180-degree changes in lifestyle, or the same for some of the cancers, because it's a threat to life, isn't it? So those with, poorer lifestyles and poorer habits can make those changes. But I think for hip and knee replacement, we need to think about it a bit more carefully, because it's about quality of life, which is important, but it's not life-threatening. So that's where I think there's scope, because we have to think how we educate them and how we make it matter. And that's why I think it hasn't been easy so far, but it shouldn't be something that we shouldn't try to address and work with our patients.
Yeah, that's an excellent point. I think the summary, the supplementary documents that you provided are a really nice summary. So that will be either provided in the notes underneath the video, or actually we can be potentially editing it over. So we'll talk about it as it's shown. But do you want to talk a little bit more about specifics? I know that there's a segment talking about how there's a change, as you said. Do you mind talking through a little bit more detail of the peri operative before they go in terms of the food and the liquid intake?
Yeah, so I mean, we what's interesting is that people have their lifestyle and their diet, and if they're in their 60s or 70s, you're not suddenly coming in and telling them to change completely how they work, that they live their life. However, I think we do have a responsibility to educate, so that you say, if you want to do the things that you can do to optimize the outcome of surgery, we'll provide you with the education and the knowledge to do that. And then hopefully it's a choice you want to make. But if you don't want to make it, then of course that's up to the patient. So I think it's a message we need to be careful with. But I think some people potentially could think that they are, eating, well and a healthy diet, but they may not have actually any understanding of portions or of how much protein or how many legumes or vegetables they should be having in their diet compared to what they would normally have. I think the other point is in those initial days after surgery. Surgery is a catabolic event. There's a stress response, a surgical stress response that happens when you have surgery. And so the protein requirements and energy calorie components, even though you're in your bed, you're not moving around much, are much higher in those initial days after surgery. But for many patients, that's if you've worked in this space for a long period of time, you realize that actually many of them lose their appetite. They don't feel hungry as a combination of the surgery. And when they do go for something to eat, they'll probably go for sort of high carbohydrate, high sugar, those kind of easy kind of snacks that most people would go for. So I think there is something to educate. I think that may well be there is a role for supplementation in terms of shakes and protein shakes and those things, in order for patients to be able to have those those times and to respond to that change in energy requirements in the first days after surgery.
Then would you like to comment a little bit from your background on?
Yeah, it's really interesting hearing you talk about That's all. And I think what's really important is the dissection of the two key things in terms of the lifestyle factors with conservative. The term you used in the paper, perioperative, I really like, but the perioperative period for, say, a patient with NeoA, that could be a decade-long period, right, where they could be at a point where they start managing conservatively or get an orthopaedic opinion, and that's very different to that acute phase pre and immediately post-surgery. One thing I'd be really interested in is, what was it, obviously all three of us are all physiotherapists, what was it in your career that like sparked the flame of passion for this area of research? Like, what was it that made you think this was so great?
So yeah, I mean, before we go on, I think you bring up a good point, which I should acknowledge and agree with you about the conservative management. So I've been talking very much about that acute operative period, but of course, 90+% of patients having a hip or knee replacement will probably have, osteoarthritis of the hip or knee. That's the main indication for surgery. So I agree with you. Quite often, these patients could have had, or could their conservative or non-surgical pathway, the years previously. I think there's a lot to do there in terms of optimizing the care for patients. And of course, like I'm sure with your PhD around knee osteoarthritis, there's lifestyle changes that there are important in terms of weight loss as well, isn't there? So that's something at a non-surgical stage, which is really interesting. So if you think about it, we need to, that's where a lifestyle ongoing change should happen. So ideally in the future, we would have patients that have gone through that optimized non-surgical pathway with the lifestyle, the education, the exercise. And that then either works and they never need surgery, or it works for a period of time that despite doing all of those things, they then need surgery. But we've already got to them about lifestyle, either weight loss or rounded eating, all those things beforehand. But I think that's a kind of utopia that we're some way away from, both in clinical practice and society. So yeah, just to sort of flag that point that I've been talking about, that acute piece. In terms of what makes it so interesting, well, if you go to Stuart Phillips's work or many others in the area, when you look at exercise therapy or exercise in older patients, this is very much a summary, but you don't ever get better results that when you use nutrition plus an exercise intervention. It's the plussing of the two together that gets you the best results, and that will always outperform just exercise alone or just nutritional supplementation alone. Do you see what I mean? So now, of course, it depends on the patient group, and I'm being massively summarizing that, but that's where the interest came, because when you suddenly realize that actually you need that effect, especially in older patients. So it stands to reason that we need that effect in orthopaedic patients, and it may well be why some today actually the exercise and the rehab that we use post joint replacement, actually the studies are pretty disappointing in that we've just had studies from Denmark show that supervised versus non-supervised exercise, there's no difference in terms of the outcome, and there's probably something there about the dose of the exercise, but then what we're also doing in combination with that. And of course that will only be some patients that relevant, because other patients, their diet will be good enough already, which is fantastic.
Have you, this is also because seeing patients post-operatively is what we all do as physios, but I guess it's just from your CVs and your backgrounds, both of you have got a passion for this area. If I was to be a physio who hasn't really worked as much as you, anywhere near as you, Tom, in this area, have you got sort of potentially some bite-sized takeaways that some physios could take from this podcast? So tomorrow they could go, right, well, 2 or 3 pointers for perioperative if they've got patients coming up for surgery, and then maybe 2 or 3 pointers that mostly will cover. I know, well, it's like trying to boil a storm there, isn't it? You can't really summarize it that easily, but does that make sense?
Yeah, I think the little I'll give a little bit of background for the rationale of the PhD project I'm doing. That I got obviously very interested in the nutrition, and then very clear on the guidelines that conservative particularly at the knee, OA, we need the exercise, the self-management education, and the weight loss. And that weight loss there's this evidence to practice gap where patients aren't being offered weight management advice so much. So I think we're probably, maybe if we're talking about physiotherapists, I'm still not 100% certain, and this would be a good point to raise with you, Tom, of what the role of physiotherapy, a physiotherapist particular, is in delivering nutritional or weight loss or weight management intervention, because it's a bit of a grey area with the scope of practice. And I think that's probably where the profession maybe needs to evolve a little bit, in terms of who delivers this education or advice.
I think you make a good point, and I think that's where, research-wise, that's why it's so important to work collaboratively with colleagues in those professions, as I've done. I think how a practical example about how we've utilised it over the last couple of years. So for many years, I've worked alongside an orthopaedic surgeon in an orthopaedic outpatient clinic called Professor Rob Middleton. So he's a hip surgeon, and I don't know, 15 years ago I was called an ESP. I think I'm an advanced practitioner, whatever I'm called these days in that clinic. We're seeing referrals from GP, and then we're making a decision whether they're listed for surgery or whether they're conservative treatment or whether they're medically unfit and need to go elsewhere. And we've worked hard on that model, and we've worked with an organisation that's available to us locally here called Live Well Dorset. And the key part for there is, when we're making a decision around surgery, it may be that we don't need surgery, so we're trying to promote a conservative management regime. So that's where we will refer them into one of our programs that we have locally, such as the Chain program, which is a cycling and education program for people with osteoarthritis of the hip. But also, if their weight loss is required, we'll also advise that that's required, not only to help with their symptoms if they're not ready for surgery, but also for some patients locally, we have a limit of BMI of 40 for surgery. They may well need to lose weight before we'll list them for surgery. So what we reflected on was that didn't really work very well when we just delivered that message to them and they went out the door, because where do they then turn? What do they then do? So Live Well Dorset, a public health part of the public health team in Dorset. So they had people who work for them in clinic with us, and I would bring them into the clinic room, and I would then advocate their services to the patient, in front of the patient, just so there was a clear value to the patient of what we thought Live Well Dorset could offer. They then had a health coach or advisor that would then talk to the patient for a bit, in more detail about what the patient wanted advice on. And for us, that was all things around lifestyle. So it may have been smoking or alcohol cessation. It may have been weight loss. It may have been loneliness and social isolation, or it may have been wanting to find exercise solutions. And of course, they're almost like then the wait time, where they then register the patient, and then they then appropriately put them onto one of these programs or signpost them. Now, it's not perfect, but we definitely acknowledge your point, Ben, that it wasn't our role to do that, but we did think we could get better at the handoff between things, because before that, and what will happen in most places, it will be, oh, you just need to go and do that, off you go. And then, patients completely bewildered. Where do they find it? Who do they go? What can they trust? Sort of take that step forward.
Yeah, I mean, even from my point of view, but still very scratching surface on nutrition compared to both of you. But yeah, I would get confused as a physio, as Ben said, sometimes when so having that background for yourself, and that service definitely, I guess, would give patients the support. So in terms of the actual perioperative component, that's a part of it. And then the big part of your research, Tom, was this post-op, which is where generally physiotherapy was born out of, essentially, isn't it? So in terms of from that, what would be advice post-op? You mentioned protein. Do we know
It's sort of specific nutrition advice.
Well, I'm talking
or for a physio to use.
No, so it's specific, yeah. So like post-op protein intake and then some.
Yeah, I would say, well, the key thing is making sure it's completely reasonable for a person who doesn't have to think, oh, well, maybe I'm walking around or whatever, and now I'm lying in bed doing nothing. So I don't need to eat much, and I'm in pain and I feel a bit nauseous, so my appetite's down. So giving them a brief understanding of the stress response, and that these amino acids and energy is needed for both for the healing and for minimizing atrophy, which a couple of weeks down the line we're going to try and be building back. So we want to flatten that curve as much as possible. So energy target being hit and protein being the key one, and then a wide range of antioxidants, micronutrients would be the kind of key pillars of that.
Excellent. Any further on that, Tom? Post-op phase, because
Yeah, I think it's interesting, isn't it? So we've got a couple of bits here where we're aware as a profession of staying in our kind of lane and our kind of scope, but then we've also got to acknowledge that, you know, a patient doesn't stay in one lane; they live their life where all of these things interact. So that's where, again, we have to meet the patient where they want to be met, don't they? So some patients really want to know, how could I, I really need to get back, what could I do? And so they're going to be the ones that actually want some really in-depth advice. Do you see what I mean? And you can talk to them in a more technical manner. You can say, okay, well, do you want to do a food diary? Let's have a look. Do you know what I mean? That's the kind of level, but that's not many patients, is it? That's a few. I think you've got to meet the patient where they want to be met, and then that's whereby, okay, if the conversation is that, yeah, they would really like to lose weight. Let's say that as an example with an osteoarthritic patient, because that's probably one of the most common, ones that a physio would encounter in practice. So again, that's where, again, depending on, where your setting is, it's, you've only got so many sessions you can see them, and you can only do so much in a session. So you have to prioritize the value you can provide. But I think that's where, within your clinic setup, you as a team should have known local points where you've got relationship with people that you can hand off people or recommend people to local services. I think as a physio, if you're working in practice and you don't know those things locally, I think your practice and your team needs to do that, and you need to build bridges so that you can be more effective. So rather than it just being, yeah, I think you need to lose weight or need to do X, Y, and Z, you can say, yeah, and we've got a really good connection with the service locally here. I can make an introduction. Do you know what I mean? I think you sometimes have to just have that step further. And I think the other point there also is when we're doing that, the patient has to have the understanding that it's up to them, isn't it? So and again, that will differ depending on how you practice physiotherapy, because there are different approaches, but very much my approach and lens is around education and promoting self-management for the patient themselves. Do you know what I mean? With rather than a dependency on the professional. So again, that needs to be part of the ethos of care, whether it's exercise, whether it's diet, whether it's lifestyle, all of those elements, I would argue.
Absolutely. And when we look at patients, you mentioned the kind of patient tracking, and I've been with his really good Instagram page and the work he's done in the presentation. So food diaries, is that something that how have you integrated that? Is that something you find patients quite get defensive of? They don't want to jump in with that? Or?
I think, again, we've published one paper where we had utilised food diaries where we looked at the diet the week before surgery. But if you look in the literature, there's very few publications in that area, because I think it's really hard.
Really interesting.
It's really hard to persuade people to do it. And if you've ever tried to do it yourself, it requires discipline. But things might be changing. The apps now with AI, you just they're getting a lot quicker at being able to tell you, the number of calories, what was in it, So I think technology is coming forward. Whether the people we want to study are good with that technology is another question. Do you see what I mean? But,
Yeah.
I think yes, they're useful, but it's dependent on, in a research setting, persuading patients that it's going to be valuable and they're going to be part of something worth doing.
Mm-hmm.
Yeah, I was going to bring up, reading through some of the work. One thing I found really interesting was in the 2020 ERAS consensus statement, how the perioperative nutrition was a strong recommended but evidence level low, and I think it even says there's no studies showing this. And then in the 23 paper with Matteo, it says orthopaedic patients generally present pre-surgery with suboptimal intakes ranging from 50 to 90%. But so I'm a bit of a literature nerd reading through these, but the papers that were referenced in support of that point were a cohort of 55 people from Canada and 98 from a hospital in Zambia. So that was the support for, this is a big problem, and that's not a huge evidence base to draw that conclusion from.
Yeah, I think it's hard. I think it's hard. It's hard to find, because it's not being researched. It's hard to find papers.
Yeah.
I think in terms of the bits of work with Matteo that are interesting is, as we move forward, I think we'll start to understand more the relevance of those patients who, it's not so much malnourished, but undernourished or sarcopenic. Those will be, I think, the future where we've got potential work to do. And it's not going to be all patients, but it's a subset, because most patients after joint replacement do really well. But there is still actually a lot of patients who, when you look at the data, they never reach, at 6 months post-op, they never reach their pre-op activity levels, even though if you ask them, they say they're recovered and they've done really well. So I think that's of relevance when it's such a costly operation and we're doing so many of them each year. And it's also of relevance that, we'll be working till we're 70. I'm sure you guys are a bit younger than me, but, and if you think about it, people are going to have to be active, for a longer period of time. So yeah, you're right. The initial guidelines, and what was interesting also, when we wrote the hip and knee guidelines, we were the first ERAS guideline that didn't promote the use of a carbohydrate drink immediately pre-surgery, because again, at that stage, what we were looking was for any studies based in ERAS or fast track settings where there was basically a trial to show that was the independent variable that had helped achieve discharge criteria quicker or not. So again, it's really difficult with these consensus statements because there's not 10 brilliant randomized controlled trials on every topic. So you're then making this you'll continue going from this kind of, you're trying to use the grade criteria, but trying to go from evidence to clinical opinion to try and get something that takes the field forward, but is evidence-based and can be sort of, stood behind. So yeah, you make a good point. It's difficult with the literature currently.
Yeah, no, it wasn't I think it's, I found it interesting at how little research there is, but hopefully there'll be more. I think one thing that's probably important we have this conversation is that we are, because we're kind of diving between conservative OA and perioperative nutrition, is when we're talking about conservative OA with weight loss for those patients with an elevated BMI, and then when we're talking like you mentioned, Tom, perioperative in that more acute phase, we're more worried about the other end of the scale, like the malnourished and put weight up. So at the moment, I'm doing a scoping review search, and when constructing the search strategy, one thing we had to consider was when bringing in terms like nutrition or diet, because I'm specifically looking at weight management and weight loss, that we could end up looking at two different things, where some physios are giving nutrition advice to lose weight for conservative OA. And then the next paper is also talking about physios giving nutrition advice, but they're talking about increasing nutrient intake to prevent malnourish. And so that's probably a really, really important distinguished point to make at this point.
Yeah, I think it is. Yes, we're jumping around, so I think you're right to flag that to anyone listening that's important. And I think, you know, the other bit that Matteo and I've been discussing recently is so for those patients that have had osteoarthritis of the knee or hip and then are coming to surgery and then they're trying to lose weight to get their BMI, you know, under 40 to have surgery. I think the first thing to indicate is that a higher BMI does increase your chances of complications, longer length of stays, readmission. So having a cut-off point for BMI before surgery is a sensible thing. Now, it's something that is very difficult for some patients because if you're just above it, they obviously feel, you know, like they should be able to go ahead. But you have to kind of have a cut-off point at some point, and 40 is what's most generally agreed. The debate of where that should be, I'll leave for others. We'll just go with what the current, you know, practice is. But what's interesting there with Matteo is we're saying, well, you know, some patients will come back and they say, well, I can't exercise, so I've just, you know, they basically crash diet for 6 months to get their calories down, lose weight. So they come back and they're obviously delighted because they've lost weight and they're under there. But I'm sure, you know, and when we're seeing any of our patients, we always ask, have you had any sudden weight loss? Do you know what I mean? Like, if there's sudden weight loss, we're worried about it, don't we? And you know, there is something to be said there that, yeah, we want them to lose the weight, but if they're suddenly losing weight by, you know, real reduction of calories, you know, there's a safety issue there as well, isn't there? Because they're likely to lose a certain level of muscle mass as well, and their sort of general reserves, you know, for recovery. So linking that to your point, I think there is something, and one of the other papers we published recently was talking about, malnourished, undernourished, sarcopenic, and there's also these sort of, you know, you can be kind of skinny fat, or all these different terms that are now in the literature, which, you know, even though you don't look overweight, that actually you've not got much muscle and you're actually carrying quite a lot of body fat. So I think, again, there's something for us to learn in physio about how we can, you know, understand which of those groups our patients fall into, so then we can, you know, tailor treatment and advice accordingly.
How, Tom, do you see the research? If we agree there's not much research on it, with the research head, what are the ideas you'd have for researching this? Because I liken it, there's a 2016 paper where they looked at using omega-3s for knee OA in Australia, and it's low dose versus high dose. So the low dose is kind of your standard 1 capsule per day, and high dose is 10 times that. And the reason there's no control group is that it was unethical to prevent a group of middle-aged people from not having omega-3 supplements, and also giving them dietary advice of you must not eat oily fish or avocados or anything. And that was unethical. And I imagine ethics committees would have a similar view on you asking for a control group of a study where the control were restricted from getting nutritional, in optimized nutrition, or being told, oh no, you can't have enough protein after
crash diet.
Well, so what do you think the research will look like to build up this evidence base that there currently isn't, bearing in mind that there can't be really a control group without it being seriously unethical?
Yeah, I mean, it depends what you're looking, what the variables are, doesn't it? But I think the first thing that we can probably say is that I don't think we have a deep, you know, good quality, detailed observational cohort studies in this area. So the first step would be as many patients as possible, but in very detailed observational cohort studies. So you wouldn't need to randomize. But what I don't see, I'm not aware of in the literature, is, you know, almost that ongoing food diary for those patients before and after, but also that link to their kind of baseline measures and also their, you know, post op, you know, measures as well, because we'd be wanting to try and link this to, you know, an objective outcome. But these things are difficult to research. So last week I was in Toronto for 2 days at a meeting with experts from around the world looking at the use of, you know, wearables in tracking mobility and walking in older adults and the older population. And, you know, in terms of research, those tools offer us great opportunities, but there's so much complexity to how we interpret that and how we use them. So yeah, I think research is going to be, yeah, it's going to be possible in the future, but I think the first step is probably very, you know, tightly controlled cohort studies, so we understand the true trajectory, and then I think it's then about identifying the groups that would benefit most from a nutritional intervention, and I think that's important, because just saying everyone gets it, that's good advice, but the signal will be less, because there will be patients that do well anyway, as they are doing now. So we need to identify those groups that are most at need. So again, it might be that hip and knee is one area, but another area it's harder to research because it's not elective. But, you know, patients with a fractured neck of femur, they are typically frail elderly patients where I'm sure there could be more done in both an exercise and a nutritional state, where there could be, you know, a real benefit for these things in the future. So again, when you're thinking about trials, yeah, you've got to think about the design as you have with the ethical component, but you've also got to think about, you know, what's the target group, you know, for the intervention. And then I think more broadly, I think the other question then is whether it's about supplementation or advice and life and change and getting people to change their diet. I think I'm very much, you know, for, you know, lifestyle change if we can, but then around an operation where there is an acute need for that patient, that if we can identify and we can change with supplementation to help a better outcome for that patient with operation, I think that has a role. But I think my preference, just like it is in my diet, is that I eat a broad diet with lots of plants, lots of vegetables, lots of different things, so that I don't need to be taking lots of supplements. And I think that's probably the best message, isn't it? But I acknowledge there's socio-economic parameters, education parameters, availability parameters to all of those things.
That was the point. I was going to break the undernourished, malnourished population. A bit of evidence, I'll have to find the papers on, but that the impact of micronutrients or kind of the supplements seem to be a bit more successful in those who are already undernourished versus those who are healthy. Is there room for those who is there like a blanket one, or would you say that you would pick and choose those patients? You say, right, well, this is your protein shake, this is the supplements from omega-3s, or would you be cautious about that sort of information? Does it make sense?
So yeah, I mean, like with all of these things, there's a cost component, isn't there? So that's the other element. So in terms of if your hospital was going to provide them, you know, and you was going to provide you with a week before or a week after of, you know, a daily supplement, whatever, there's obviously a cost component to that. So therefore there has to be some evidence and rationale for why you're giving it. So I think it will be identified patients, those that need, but, you know, if you currently, I wouldn't say there is nutritional screening in hospitals, but most use very much tools that are based for identifying malnutrition, which is not what we're talking about here. We're talking in most terms about undernutrition, which won't always get flagged. Those scores are not designed for that, so they're not sensitive or specific enough for that. So I think some way of screening and identifying, so there needs to be a conversation with the patient about their diet. But then I think then it's about education and information and allowing them to understand, what they could eat in the days before their operation and in their days afterwards. And it's not just about educating them, but their family. And also, like we did in the paper, just try to give different options. Do you know what I mean? People have different tastes and different dietary habits. So I think at this stage, that's what we can do. What's interesting, North America is very much, very heavy on the supplements, isn't it? And those elements. And what they're seeing there is there's been a big change post-COVID in joint replacement practice over there. So lots of patients are now treated in ambulatory surgical centres, which mean they're kind of day case surgical centres. And in those centres, it's very, very commercially driven. The surgeons can be hard for business. And there are a number of companies now that are specialising in selling supplements for patients, and patients will buy those individually themselves. And they'll normally be like a package where there's a course that they take for the 1 or 2 weeks before surgery, and then they take after the surgery. And what's interesting with that is, I suppose, is that patients are buying into it because they have to individually buy that and they have to go, forward. So whether that says something about the patients in England is another thing, but it does show that to patients in the States, it's making sense, and they're thinking, okay, well, that's something I want to do.
Mm. And with that group of people who are buying into a package, obviously there seems to be, as you said, financial accountability. If you're financing something, and there's that guidance to say, right, this is dosage, these drinks. Do you think from those colleagues in America that type of nutritional management package is beneficial? Just doing.
So I think from what I understand, because I've asked those questions as well, I think they're doing sort of evaluations currently. I mean, my personal thing, for a patient who has a good diet and eats well, then they probably don't need it. Do you see what I mean? But I definitely think there are a proportion of our patients that will really benefit from it because they're not getting enough protein in their diet. Now, some of those could be educated, and I talk about protein, but there's lots of other factors. I'm not just simplifying it to that. But there could be some that could be educated to change, but that is something that hopefully we could do earlier in their treatment pathway at the osteoarthritis stage. Do you know what I mean? But I think for those patients who haven't done that and get to the acute stage, you're not going to say, okay, well, you've got to change your lifestyle in the next week and completely change what's in your cupboard and your cooking habits, are you? Do you know what I mean? But if you take this supplement for the next 2 weeks, that will really help you. I think that's more achievable.
Yeah, I think in many ways to liken it to a physio situation it would be the equivalent of making the statement and saying, right, working on terminal knee extension and quad activation is helpful for people with knee OA and it's really, really helpful for everyone. But that's where a good assessment will come in and say, well, actually, it's most important for those people that have got a flexion contracture and it's the same point applied to the supplementary stuff, that for those people that are already hitting all their targets, once you've hit your target of vitamin C for the day, you don't really gain anything by going above. So if you just blanket say, oh, is that supplement good? But everybody in the cohort that you're talking about already gets enough vitamin C from their diet, then the vitamin C supplement will look useless because it's not changing anything beyond.
Yeah, doesn't the efficacy is a bit skewed there. I want to ask Tom, in your in terms of assessing for malnutrition, assessing to the point where you could say almost factually that they are undernourished, malnourished. Are we doing a full blood count? Are we doing standard? How do we get to the point where you can say that they're at that stage? Is it that simple?
Yeah, really good question. I think in clinical practice, we, in our orthopaedic world, we're very much more simple at this stage, and I haven't pretended otherwise. So preoperatively, BMI is the main one in terms of if they need to lose weight and are over. In terms of those that are sarcopenic or frail, I don't think at this stage, routinely, in routine practice, not in the research studies that I'm doing, but in routine practice, I'm not sure it's anything more than the kind of generalized nutritional screening score that they do at pre-assessment, like I said to you. And of course, then they have all their pre-assessment bloods and all of those elements done. But I don't think there's anyone actively managing that and acting on that. But we've come a long way. We've come a long way, because if we go 10 years ago, we weren't doing as much as we are for screening for anemia preoperatively. But now it's routine. Most hospitals, they're screening for anemia, and those patients that are anemic are getting iron therapy preoperatively. So you can see that we are moving towards that way. And anemia is an example of one of the ones where it's most important, isn't it? So practice is changing. In our setting, it's not perfect, but in our research and our studies, we use obviously a range of different tests, but we use bioimpedance. It's not perfect, but it's one way of giving you some more details over and above, a BMI score. So it's just then when you get that is how you articulate that to the patient as well, isn't it? And how you talk about it with them, so it's meaningful for them.
So with that, someone who has, both of you have extensive experience, research, and your clinical gut is pretty strong. You can trust yourself that actually this patient look as well. They might say they've lost weight, but I'm not sure. I'm going to pull the trigger and get them full bloods checked. Do you have any tips for those who are potentially just starting? Maybe they're not sure about the patient. You said the skinny fat type, body type, and things that you picked up on that maybe go, well, actually, it's not sitting right with me. Let's just get them checked for malnutrition, because as you said, it's easy to look slim, and maybe that's great. You lost 2 stone, but micronutrient wise, and they're malnourished. So then the post-op outcomes potentially are not doing as well, or maybe they're affected.
I think you're getting this data from your all-round, subjective and past medical history, aren't you? So, do they live alone? Who do they live with? Are they still going out and doing the shopping? Do you know what I mean? If you asked about them, are they preparing their own meals? And in my operative setting, clinical practice, I can ask all these things, because I ask, have they thought about how they're going to do that after the operation, and because they're going to be on crutches for the first, days at home. So that kind of more kind of holistic question is part of what we talk to them about. So I think then if you realise that, and you've seen how they walked in, they're not really walking very far, they're not really going out to the shops that often. Do you see what I mean? And their capability.
Yeah,
I think then that builds the picture, along with, as you quite rightly say, the eyeballing of whether someone's, frail or less frail, and how they move. So I would say, in not an exact science, but I would say through the subjective, the social, the past medical history, the observations of what they're doing, I think you can build a picture of where to follow up on with these kind of questions. And then again, that's where we use the Live Well Dorset guys. If we think that's an issue, then that's where to invite them. So big ones for us that have relevance for calories is alcohol. It's amazing. People don't realise the amount that they'll say in terms of their drinks, and when you add that up in units, it's quite staggering what people think is just routine, compared to what is the guidance of what people should be doing. So even changes to that would have big calorie changes for some patients.
Tom, do you think that physiotherapists in entry level training should have this as part of the curricula of study? Because I obviously can only speak from ours, but we didn't. You could have got 100% in our physiotherapy course at undergrad and not known what protein, carbs, and fats are. Do you think that this is an area that should be mandated or brought into our training?
That's a really good question, because I also know how much my colleagues struggle to get all the content in a course in anyway. Do you know what I mean? So where do you struggle? So I think it also, that I'll probably not answer it directly, but it's probably something that, in terms of, let's take physio, because all the degrees are regulated centrally, it would be a central decision, wouldn't it? But I do think, like you have and like you guys are, I think the key message for me is you leave undergraduate physiotherapy course being safe to practice, but with everything to learn. And I'm 20 odd years down the line, I've still got everything to learn. Do you see what I mean? So that I think that's the that's the biggest message. I do think, and this is not so much about undergraduate teaching, but more we do have to think maybe more broadly as a profession, especially those of us who work in musculoskeletal orthopaedics. Historically we are pretty one-tracked about bone, muscle, and joints, aren't we? Do you know what I mean? Where they exist,
especially just qualified.
They exist within a person with a lot more going on. A lot more going on in terms of their body systems, but a lot more going on in terms of their lifestyle and their social context and their environment and where they are. That will have a massive bearing on their pain or their injury or whatever you're treating them for. So I think there is something broader for us as a profession, thinking a bit bigger than is the tendency that it's all biomechanics and it's all a degree here and a degree there, but that's probably more of a personal view.
Absolutely. I realised that we're getting slowly running out of time. We've got a bit of time left. I just wanted to ask Tom. You mentioned that you were close to almost publishing the CLEAT study. Is there? How's that coming on?
Yeah, I'd love to talk. Yeah, thanks for asking. So, CLEAT study is a NIHR-funded randomised controlled trial looking at the chain intervention versus standard or routine physiotherapy. So chain is an intervention for patients with hip osteoarthritis. It's a 8-week program where each week patients meet as a group and have half an hour education session and then a 30 to 40 minute static cycling session. So it's something we started back in 2014 based upon the NICE guidelines. And my colleague, Professor Rob Middleton, was on the NICE committee that drew up those guidelines for OA. And it came out that exercise, both local muscle strengthening and cardiovascular exercise, was the thing to do. But actually, there's very little guidance about what that should be, what exercise, how much, and what that should look like. It was my feeling and observations that any exercises we were giving to patients were very much underdosed, because it was 10 hip flexions, 10 hip abductions 3 times a day. What were we hoping to achieve? So we started basically when I'd first qualified. I'd done cardiac rehabilitation to earn extra money, and so we essentially used their model, which was an education and group exercise model. Now, in cardiac rehabilitation, you've got to persuade people to get their heart rate high, because after their surgery, they're worried they're going to have another heart attack. In osteoarthritis, it's similar, but the difference there is you've got to persuade someone to move a painful joint and get them to understand that if they move it, it'll be less painful. And actually, if they stop moving it, the pain will be worse. So we use a graduated static cycling session, and we did a pilot study back in 2014 over the coming years, and we got good results. And that was for patients referred to physio. And then we repeated that study on patients who were referred to orthopaedic outpatients for a secondary care opinion on surgery or not, and we still got good results. And so then we got funding from the NIHR to do the RCT. So that's hopefully going to be submitted before Christmas to one of the big orthopaedic journals, and the results, I can't give all the details, but it was really favourable for chain, which is excellent, both from a clinical and an economic standpoint. So I think this idea of using group therapy is really interesting, because you can treat more patients and give them more contact over a longer period of time than if it's one physio seeing one patient at a time. I think the other thing to say is that we run it in a leisure centre. So I think that's important. You've got to get people out of the hospital environment if you can, and understanding that leisure centres, are accessible for them. And we've worked really closely with the one down here in Bournemouth. That's important because exercise works for arthritis, but for only as long as the patient exercises. So it's no good we do 8 weeks and then they stop exercising. So by doing it in the leisure centre, they can then join the nice and easy spin session that goes on after our session that we run, or they can go to the aquafit or whatever's for them they can do. We don't mind, but we just want them to understand that it only works for as long as you keep exercising. So that's why that link with those kind of community setups is so important.
That's really interesting. I thought that that thought process of helping them transition to normal routines is such a simple concept, because we've all done at university and placements, we've all done classes in the hospital, in the gym, and it just, most patients don't like being there, but it's such a simple but clever way of doing it, because you then got people who are not de-demonizing, or de-threatening the kind of whole gym scenario, which they don't like anyway.
Because they don't think there's anything for them, and also some of them have not been in there, for years. I think the other thing to say is the static cycling works really well, because you can be 40 odd like me with an arthritic hip, go in that cycling group, and I can work at whatever's good for me next to someone who hasn't been on a bike for 40 years and is 70 years old, and they're just going at a slower pace. The cycling is designed so it's fun. It's run by a spin instructor with a specially tailored sort of thing, but we've got the music, we've got the lights on. So again, it's about making it like what people normally do. So by the end of the 8 weeks, they can't believe that they can do practically a normal spin session, and they know that that's something they can then do. Whereas at the start of the course, they'd kind of written off the fact that they could actually, walk or do anything. And I think that's important. The other thing that we've slightly changed it, and it's great to hear of your group experience, but we use like a senior physio to facilitate the education group. So the education is a short video, then it's a facilitated discussion. And again, when you talk about undergraduate training, that's something that I think we don't ever get really explicitly taught, do we, how to facilitate groups. It's much more on a one-to-one basis. And if you're a student, you get some groups, that's lucky. But actually a skill of managing 10 or 15 people in a room with different agendas is quite difficult. So again, I think that's something that we should try and improve and try and work on, as a profession, because with the volume of patients we have in the NHS, we need to think of smarter ways of seeing them in a timely fashion.
Yeah, so with the CLEAT trial, was
we've got about 3 minutes just
with
before the online thing comes up.
With the CLEAT trial, so the control arm just got standard physio.
Standard physio. We didn't adjust it in any way. Those patients made improvements in the primary outcome measure as well, but the ones that had the chain intervention improved a lot more. It's not saying physio is bad, just saying that there may be other ways of doing it that could get better results.
And then very lastly, will you be following up those patients longer term to see, a year, 22 years down the line, what happens?
Yeah, so hopefully, if I get another grant to do it, so it's all about getting some funding. Hopefully. That would be the way. And I think we followed up the initial cohort and published on the 5-year follow-up of the first cohort we did. And we found that about 50% of patients never returned to the health system for an opinion on their hip. So they were didn't need any more thing, but then about 50% did come back, and a large portion of them went on to have a hip replacement.
That's excellent. We'll definitely look out for that and try and take some of that into practice. That sounds amazing. I think it would be quite a safe time, even though we're actually getting into a rhythm here and we could actually talk a bit longer. I think we could. It would have been great, but yeah, this recording is going to finish very soon. So I just want to say thank you to both of you. It's been amazing that you've taken time out to come on the little podcast. Tom, I've learned a lot in this one chat with you. I'll definitely be diving into a bit more work that you published to help out my end. So yeah, thank you very much for that.
Yeah.
Thanks for the invite, and really good luck with the podcast. I think it's a great idea and a great thing you're doing, and so I hope you look forward to listening to the other episodes. And thanks for inviting me.
Awesome. Thank you very much. We'll finish there.
Thank you.
Excellent.